Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Keerthana Pakanati.
Dr. Sperling, Dr. Blumenthal, welcome to the Heart of Prevention.
Great to be with you, Keerthana.
Yeah, glad to join.
I'm Keerthana Pakanati. Thank you guys so much for being here. I'm a current cardiology fellow and your host for today's episode. And before we dive right in, let me tell you a bit more about our esteemed guests. Dr. Roger Blumenthal is the Kenneth J. Pollan Professor of Cardiology, Principal Developer and Director of Johns Hopkins Cicerone Center for the Prevention of Cardiovascular Disease. Dr. Laurence Sperling is the founder and former director of the Heart Disease Prevention Center at Emory, currently the Katz Professor in Preventive Cardiology at the Emory University School of Medicine and a Professor of Global Health in the Rollins School of Public Health. So in case you haven't already been able to tell based on the descriptions, we're going to be talking a lot about designing and building a preventive cardiology program from scratch today. So to kick us off, I'd love for both of you to tell us a little bit about your journey in preventive cardiology. How did you get here? When you were in my seat as a fellow, where were you thinking your career was going to be headed, and so on? And Dr. Sperling, I'll have you kick us off.
Sure, this is a great way to start, and it really harkens back to the title of the podcast, The Heart of Prevention. You know, myself, and I know we'll hear from Dr. Blumenthal, we might be seen as pioneers in some ways, that we started some of the first preventive cardiology programs in the country. But really, I feel like I'm standing on the shoulders of giants and have had a lot of support throughout my journey. And I started out in molecular and vascular biology, and I started realizing that we were understanding the disease atherosclerosis a lot better, but also started to begin to have the tools to address it on all the tiers of prevention: primordial prevention, primary prevention, and secondary prevention. It was also activating for me to observe many parts of our health system that were already in place. We had a cardiac rehab program, we had a hypertension program, and we also had one of the top angioplasty programs in the country. Emory's the home of angioplasty. And I started realizing many of our patients were coming in. We were, fixing them, sending them out into the wild blue yonder. But we were not anchoring this in the concepts of prevention that we're building. And so I actually designed my own fellowship training program, in addition to things that fellows typically learn to become cardiologists, with the support of my program director, Marshall Runge, and also the support of the institution. I designed my own training program in the pieces of the puzzle to develop expertise in cardiovascular disease prevention, including training in imaging. Back then, there were only 4 CT scanners for the heart in the world at the time when I started learning cardiac CT. I know Roger has his own journey, and he's been such an important mentor to me and friend, and has provided guidance on my journey to this day.
Well, thanks, Larry. Keerthana, it's a pleasure to be with you, and Larry is clearly one of my closest and best friends, and we've had a great journey together over the years. I guess I started getting interested in heart disease when my mom's uncle, who was my beloved godfather, developed a heart attack back in the 1970s. And my father was a pediatrician. He made sure that as a family, we changed some of the dietary habits, and we were one of the sort of few families on the block who really cut back on saturated fat and really tried to have a much healthier diet. And I went to college at Hopkins. I became really good friends with a dynamic athlete and coach at Hopkins named Henry Ciccarone, who was the lacrosse coach. And during my time at Hopkins, we won 3 national titles in 4 years, and I subsequently went on to medical school and residency, and then during my residency, Coach Ciccarone, actually during my residency, Coach Ciccarone had the first of 3 heart attacks, and he ended up dying at the age of 50. After his second heart attack, he wanted to do something to sort of raise awareness about heart disease in the Baltimore area and the Maryland area. He was a sports icon, and we arranged for him to do some public service announcements for the NBC affiliate in Baltimore about things to be aware of to lower your risk for heart disease. But just before he was going to do that, he died of his third heart attack. And just like Larry, I realized that Hopkins as well as Emory really had not done much in the field of prevention. We had a advanced lipid disorders clinic that Peter Kwitovich ran, but from a cardiology perspective in general, it was much more about angioplasty, bypass surgery. And I was the one who got a lot of Coach Ciccarone's former players and friends in the business community pledged the seed money for what we hoped would be a comprehensive clinical and research center geared to the disease that took his life. So, like Larry, we've tried to build up preventive cardiology, and we started off focusing on people who had a family history of heart disease and trying to figure out what were the best ways to manage them. And then, just like Larry, we've grown quite a bit, and prevention means a lot to so many people. And really, Larry and I look at all patients as preventive cardiology patients. Either we're trying to prevent the first cardiovascular event or a subsequent one.
Yeah, and of course that personal motivator as well. My grandfather had heart disease in his 40s, and he went on to die at a young age. So understanding the impact of heart disease on families, really feeling that, understanding that was a big motivator for me really throughout my personal and professional journey. And really to this day, it's all about the people we serve, their families, the communities, and prevention is an opportunity for all.
Yeah, I love that. I think, talking to different preventive cardiologists, there's just such a personal passion and inspiration behind everyone's journey. And I think especially for trainees, hearing kind of the how you got to where you are and what led you to there is truly inspirational. And so I appreciate y'all sharing that with me. I kind of wanted to chat a little bit about maybe getting into more of the nitty-gritty, but these building blocks. And from a preventive cardiology program, when you were starting the program, what were your thoughts about the clinical, operational, academic, and really piecing all of those things together when you started that program?
So maybe I'll start off with that one. I think one of the things that a lot of us have learned, Keerthana, is that it's so helpful to have whether a nurse practitioner, a physician's assistant who can be multi-trained in diet, exercise, smoking cessation, stress reduction. I think that allows us to provide a great service to so many patients. Most of the patients who develop heart disease have multiple risk factors. And nowadays, with cardiologists having to deal with what were once thought diabetes drugs, it's so important, but also advanced lipid disorders, blood pressure, and having someone who's really the go-to motivator to help people realize that they can make some sustained lifestyle improvements, as well as being on guideline-directed medical therapy. And I think that's always been so helpful. And Larry certainly worked with some great nurse practitioners and in other advanced practice providers. And I think having a core person who is really motivated, it's sort of like what we used to call as the diabetes health educator, but who it can also take care of so many other things. And they can maybe see the patient on the second visit after one of the attendings has seen a patient initially, but they can also be available for more urgent visits during the week.
Yeah, I think really important to start building the team. The team is part of the success. I've been asked to help many places, I'm sure Dr. Blumenthal has as well, start up their preventive cardiology program. And so you talked about the foundation. You must have the support of your institution, and I was very grateful to have the support of our division director, Wayne Alexander, who was a basic scientist, but really, in many ways, was leading the charge in the concepts for modern day preventive cardiology. Also, the support from Virgil Brown, a former AHA president, and he started the Journal of Clinical Lipidology and the National Lipid Association. Nanette Wenger, Willis Hurst, who really was so supportive of starting our program. But just there must be a champion, and then there's got to be vision. But realize these programs that are here today, they don't happen overnight. They don't happen in a year. Dr. Blumenthal and I have been at this for quite a while, and just to give perspective, when we started the Emory Preventive Cardiology program, it was me, an EKG tech, and a medical assistant. That was the team. And the team over time grew as the demands grew. When I give advice about how to build your program, I say start with your own backyard first. And educating, my own colleagues in cardiology, our cardiothoracic surgeons, our vascular surgeons, our endocrinologists, our primary care docs, why preventive cardiology? What is the value of having this program? And it should bring value to the patients that we're seeing and helping with, but also to a systems-based approach. And then, building out that team and program has to be strategic. So I agree with Dr. Blumenthal, bringing on a talented nurse practitioner early can be really important. And then activating many of the faculty and some of the current fellows, for instance, that may be at your program or around the country, to say, what would we like to start building in the year ahead or the 5 years as we dream about the future, or 10 years. Personally, we started our program focused on clinical care, but then we quickly wrapped around the clinical care education. And we helped to start one of the first preventive cardiology fellowship programs in the country, because one of our goals is training the future leaders in heart disease prevention. And then we connected those dots to the community and then to academic pursuits. But having a leader who is also, trying to build on behalf of the population served and not just build on behalf of themselves. I know Dr. Blumenthal is a very humble, gracious, and giving leader. And those are the talents of making success.
Yeah, to just add to what Dr. Sperling was saying, I think he and I have talked a lot about sort of keeping things simple. And so we've always liked variations of the ABC approach. So A is assessment of risk, and A is also antiplatelet and anticoagulant therapy. And those are common questions people have. But B is blood pressure. And so many times, blood pressure management can be challenging, but also many times practitioners forget about the importance of lifestyle modification. And our preventive cardiology program, just like at the Emory program, we really stress lifestyle improvements at each and every visit. So you have harder to treat blood pressure. C stands for cholesterol, harder to treat lipid disorders. We have a multitude of lipid-lowering medicines now, and PCSK9 inhibitors and glycerin, and soon we may have LPA-lowering medications. We also have C for cigarettes. Sometimes we get referrals for individuals who having trouble being able to stop smoking. We have D for diabetes. There's not that many endocrinologists around, so our group sees quite a number of those patients, and also can help a lot with diet and sustained weight loss. E for exercise, and I think just trying to keep helping the busy practitioners. I like what Dr. Sperling said about, the vascular surgeons and the cardiac surgeons. They were seeing these people who many times Dr. Sperling and I would call vasculopaths, and they really didn't have the time or the know-how to optimize those lifestyle habits. Their primary care providers or primary care clinicians and some of the surgeons, but we said we're happy to take care of those patients and really work with you. And I think that teamwork aspect that Dr. Sperling was referring to is just so very important.
I feel like when you are talking about all these things, it's truly multimodality, multidisciplinary. It's just there's multiple things for every step of the process. Whether you start, I really liked how you said you start in your own backyard because you really, it starts with the population that you're treating. And, depending on where you're training, we see such different populations, and you have to focus on the clinical care and then expand beyond that. And I think the idea that you're continuing to expand and improve as you keep going, and it's not a linear journey, but there's so many pieces that come as you go. I think that's so important to talk about. And I like the ABC approach. It really does help organize that in my head and really keep it simple so you don't forget things, especially things that you repeat, because sometimes you have to repeat those things over and over at every encounter. So I liked the ABCs. That's something I'm going to stick in my back pocket for later, for sure.
Well, definitely, and I think just adding to that, A for assessment of risk. Some of the research that Dr. Sperling and his group from Emory have led, and that we've led at Hopkins, has been about ways to improve risk prediction. So whether it's imaging with selective use of coronary artery calcium, whether it's carotid ultrasounds, whether it's blood-based biomarkers, inflammatory markers like hsCRP, that's been one of our strong interests. And back in 25 years ago, when the multi-ethnic study of atherosclerosis started, Hopkins was one of the sites, and we played a key role in the design of that study. And we learned a lot about how the selective use of cardiac CT can improve risk prediction. And it's been fun over the years to see the great research that has come out of Emory as well as Hopkins and many other preventive cardiology centers.
Yeah, absolutely. I wanted to kind of talk about, you both of you being pioneers and really starting these programs when nobody really knew how to start them. I'd love to kind of hear about how people's opinions or how you had to talk to people that maybe were a little skeptical about the value of this sort of program. As I can only imagine those sort of conversations in my head, I'd love to hear about those a little bit.
Yeah, so definitely way back then, we didn't have electronic medical records, believe it or not. We didn't have social media, and things were, at the same time they were simpler, they were also more complex. And as you can imagine, a lot of skeptics about preventive cardiology. So again, coming back to the value of a program or having somebody see a preventive cardiologist. And I remember a lot of people saying, well, I do preventive cardiology, I prescribe statins. But it is a comprehensive approach to care, but also a leading way of thinking. And I really think back to the big meetings we had 3 decades ago, and there were minimal amounts of prevention in those meetings. But now when you attend the ASPC Congress, hopefully your listeners will attend in August. I know Dr. Blumenthal is winning a big award, so I look forward to that. But you go to the ACC meeting or the AHA meeting or the ESC meeting, and really the most exciting thing at these meetings is prevention. This is the future, and the future's here. But dialing back, 3 decades ago, in many ways we were ahead of our time. And I remember Dr. Blumenthal came for a visit. We built the preventive cardiology program, but we also connected it to the very first outpatient cardiac imaging center at Emory. And in that center, we had a stress lab, and we did echoes, we did carotids, AAA screens, ABI, and then we actually had a reading station for cardiac CT. And then we developed the HeartWise risk reduction program, an optimal living program. And these concepts, that we were building 3 decades ago, they're coming, full circle now as we're, really charging ahead with the CKM initiative and the Prevent Risk Calculator. But those skeptics still remain today. And I gave a couple of presentations at the ACC Summit, and the summit's focused on the business of cardiology. And the presentations were titled, I think it was 2 years in a row, Doing Well by Doing Good, the Business of Cardiovascular Disease Prevention. And the skeptics, we will call them specifically out in what buckets they're sitting in. But if we create the pyramid of cardiovascular economics for a fee-for-service health system, I always say that prevention is at the bottom of the pyramid. It's like the gum sticking to the bottom of your shoe. And so how do you create the business case? Because, no business model. Sustainability is really important. Sustainability, then growth. And then, in our main preventive cardiology center at Emory right now, in fact, I just counted yesterday, we have 10 preventive cardiologists in our center, and then we've grown across the system into our cardiovascular disease preventive network. So, the skeptics will be there, but when they really appreciate the value that whatever you do in cardiovascular disease care, a part of you should be a preventive cardiologist, an electrophysiologist, an adult congenital doc, a heart failure doc, an interventional cardiologist. They need to be dedicated to prevention as well.
Those are great comments, Dr. Sperling. To give you an idea, Keerthana, so it used to be thought that you could lower cholesterol and you could decrease cardiac events, but people would die of violent deaths or other causes. And it really wasn't until 1994, so we're talking 30 years ago, that we had the 4S study. And the 4S study was at the American Heart Association. 44 individuals randomized to simvastatin versus placebo. They all had very high average total cholesterols in the range of about 170 or LDLs in the range of about 170 or so. And that was the first study that showed a decrease in total mortality. And we went from 11.5% to 8.2%. And that finally quieted a lot of the skeptics that Larry was referring to, who said, cholesterol lowering doesn't really help. People are going to, have something else if you lower their cholesterol. But after that, we had the next year, we had the West of Scotland study, men with high cholesterol, LDLs again, very high, 180 range or so, and pravastatin decreased events from about 7.5% to 5%. And then we had the next year, we had the AFCAPS TexCAPS study that was done in Texas, just 2 centers, and that looked at people with LDLs of 150. So gradually we had more and more momentum to show that you could not only decrease heart attacks and strokes, but also mortality and need for revascularization. And as just as Larry said, I think all cardiologists need to be thinking about preventing their patient from returning, whether it's atrial fibrillation, doing an ablation, whether it's an angioplasty, stent. The principles of prevention that we have so well defined in our guidelines are so important and has been shown to decrease recurrent atrial fibrillation, heart failure, as well as heart attacks and strokes.
Yeah, certainly medicine and science is dynamic. It's in evolution. Us pioneers back in the days of the horse and buggies of cardiology, we actually, got to be there when these critically important studies were presented at meetings. And, ultimately it's about evidence. And when the evidence continues to build, we have to recognize that our approaches to care as cardiologists or clinicians or health systems has to parallel the change in that evidence.
Definitely. And last year at the American Society of Preventive Cardiology, Larry won the Stokes Award, being a pioneer in prevention, and that's the award that I'll get following his footsteps this year. And when I think of pioneers, I think of Davy Crockett or Amelia Earhart. But I think what we would consider, the efforts that we did at our institutions to be, just better quality, top quality medicine, and that's been um, really incorporated so well into guidelines. Sid Smith led the secondary prevention guidelines. Scott Grundy, who passed away earlier in the year, was the active participant and the leader of several of the cholesterol guidelines. And there's so many people, Virgil Brown and others that Larry had mentioned. And I think we stood on the shoulders of those individuals. Tony Gatto used to say, with a name like Antonio M. Gatto Jr., people referred to him as part of the cholesterol mafia, and that seemed reasonable given that name. But as Larry said, the evidence became stronger and stronger with more and more studies showing that better cholesterol management, subsequently better blood pressure control, the SPRINT trial, and BP Road study, and several others recently have shown that, if you can get your systolics averaging 120 as opposed to 135, you have fewer cardiovascular events and less heart failure. So, that ABC approach with the B for blood pressure, C for cholesterol and cigarettes, D for diet and weight, diabetes, E for exercise is so important. And I think a lot of times, as Larry and I have discussed, F can stand for heart failure. We have such great data for guideline-directed medical therapy, but also for family history. And I think what we tried to do and what Emory had tried to do is when people would come in with cardiovascular disease, whether a heart attack, need for bypass, stenting, we tried to motivate them to tell their family members about what they had gone through, and how the family members also needed to see their primary physicians to start a good analysis of their lifestyle habits and what their risk factors were too.
Yeah, absolutely. It's hard to argue with evidence, right? In theory. I kind of want to pivot a little bit, and when you were doing all this, you were earlier in your careers and things like that. What advice would you give to a cardiology fellow, perhaps standing where I am in their second year, or someone in their early career who really wants to launch a prevention program? And we had kind of touched upon building that team, but what would you say which should be their starting point, or what advice would you give for them?
Stick with your dreams. The road is not linear. There'll be many bumps along the road. Hopefully, be able to articulate well the importance of a preventive cardiology program for your health system. Don't be afraid to ask for help. There are many people who have been at this for a long time, like Dr. Blumenthal and myself, and many other experts in preventive cardiology through ASPC, a really phenomenal network of experts, and a very gracious group that is willing to help. So ask for help, find mentors. And the mentors don't always have to be at the same place where you work. Mentors can be all over the country or all around the world. Learn from stories of success, but learn from challenges that others have had on their journeys. I know you started out asking us about our journeys, and we of course are fortunate to be at two great academic institutions with excellent preventive cardiology programs. But there have been many times where I've hit a wall. I'm sure Dr. Blumenthal's hit walls, and I started realizing when you hit a wall a few times, it starts hurting. So you have to back up and rethink. But I'd say be persistent, be resilient. And some of the best advice was when I was a fellow, there was a program at the ACC Heart House, and Valentin Fuster talked about the best advice is figure out what you love, where you can give back the best of yourself to others, and when you wake up every morning, what brings you joy, and then stick with the joy.
It's a great summary, Dr. Sperling. I would reiterate, Keerthana, that the organizations like the American Society of Preventive Cardiology, ASPC, has a great national meeting. They have some great educational materials on their website. Um, that the National Lipid Association also attracts a wide variety of people, all with the same interest in prevention, while it was centered on cholesterol management and certainly expanded to the cardiometabolic scope. And I think those types of meetings are so good, and you can get certified by the National Lipid Association. I believe Dr. Sperling, I think the ASPC was planning on resuming some of their educational modules, and we expect that sometime later this year there'll be an update on blood pressure guidelines. Sometime probably early next year there'll be an update on cardiovascular risk assessment and cholesterol disorders, and there'll be other things, other prevention-related guideline updates that will be coming out. So I think some of the newer CME materials from these organizations will be updated once we have the next set of ACC AHA updates. And but education is just so very important.
Yeah, find your family, find your community, and build that network, and stick to your game plan. Dr. Blumenthal and I are big sports fans, rooting someday for the Washington Wizards and Atlanta Hawks to make the playoffs. But stick to your game plan and follow your heart.
Yeah, I
We're,
love
we're
that.
hoping Cooper Flag from Duke gets drafted by the Wizards. That'll help them out a lot. But I'm not sure, Keerthana, if you're a NBA fan, but the Wizards haven't won a championship since 1978, so that's a
Yeah, I
long
wasn't
time.
gonna say anything. I was like, I don't think they've won since I've been alive.
Yeah, I think if Cooper Flag is drafted by the Wizards, I will be joining Dr. Blumenthal for a few courtside games this year.
I love that. I'm really excited. I'm going to be attending my first ASPC this August, and they're doing an incredible boot camp for people who are interested, and I'm going to be attending that. So I'm really excited to kind of dig my heels into just gaining as much information and education as I can. So I think it's
Yeah,
going to
so
be a
we need
great
to get
experience.
together. We need to get together then at the ASPC meeting and get a team photo so you can circulate that on social media, get it out there.
Yes, I would love that.
And Keerthana, one thing the ASPC does really well is they usually have a costume theme for one of the nights, and I think in Boston it's going to be a formal attire. So the men will bring out tuxes, and women can wear
Cool.
their formal attire. And we had a cowboy. Dallas Cowboy type theme in Arlington, Texas, a couple years ago.
Oh,
So
that's awesome.
I remember it. So I will definitely be there for the Boston Tea Party.
Oh, that's a good theme. I like that idea. Just segueing a little bit, I kind of want to chat briefly about, you had mentioned that when you started this, of course, social media wasn't a thing, and there's been a lot of advances, whether we talk about technology, digital health apps, or things like that, and then also using social media to educate, using media to educate our patients. How do you really find that preventive programs should use that sort of technology, whether that's patient centered technology in the form of apps or remote monitoring, or whether that's patient centered in the way that we disseminate information to our patients? How do you find that balance between enhancing prevention efforts and also combating a lot of the misinformation, which could be its own podcast episode on its own? But I'd love to kind of hear how you incorporate those things at your programs.
So maybe I'll start off with that one. I think we're fortunate. Seth Martin and Francoise Marvel have headed up the digital health aspects of our Chick-A-Roni Preventive Cardiology program, and Seth has a large AHA grant that's looking at mobile health technologies, and he was one of the first to show that targeted text messages to a smartphone could increase a person's average walking distance by about a mile a day. And things have gone increased so much, but nowadays so many people have a smartphone, and they can, from basic to counting the number of steps that they get in a day or estimating the number of calories they're taking in. These Aura rings can provide a lot of other information about sleep and things of that nature. But in terms of social media, there are a number of preventive cardiologists, Martha Galati being one of them. There's many others who do post on social media and do a really good job at the major meetings too. And I think that can be really helpful. And I would expect that ASPC and the National Lipid Association will be doing a lot more of the patient education when the blood pressure guidelines and the cholesterol and risk assessment guidelines come out too.
Yeah, and Dr. Blumenthal knows that I'm pretty low tech myself. Try to avoid a lot of the, those social media spaces, but it comes back to something you mentioned about the myths, and we have to do a really good job about not talking about myths but truths, anchoring that in evidence. So of course there are many opportunities now to educate in different ways, and you can be creative not only in educating but approaching prevention in unique ways. An initiative going on right now is the FIND initiative, Flag, Identify, Network, and Deliver, where we do machine learning, health system approaches to finding people with familial hypercholesterolemia or elevated Lp(a). This is the FIND initiative through the Family Heart Foundation. Hopkins is a site, as is Emory, for FIND Lp(a). And we come back to, we keep thinking that AI is going to be the magical way to solve all of our problems in healthcare and healthcare delivery. But it comes back to systems approaches. It comes back to having AI improve our HI. It's our human intelligence. And I mentioned, as opposed to myths, talking about truths. But the core, the heart of prevention, as the name of this podcast is trust. And, we must build trust. We must maintain trust. And as cardiologists in general, but as preventive cardiologists, I think it's one of the really important things that we do. We're trusted in our cardiovascular community, our cardiovascular disease community, but building that trust with our patients over their life course. There's some people in cardiology that do the repair work, and that's necessary. They repair, and then they see somebody back for a visit or two, and then send them back out to the primary care team or their other physicians or clinicians. Prevention is a lifelong commitment. I tell my patients, we always sign a contract to age 100. We renew 1 year at a time.
Those are great points, Dr. Sperling, and I think the issue of trust is so important because a lot of the people, may come to us, Keerthana, about, they've read a lot of things that statin medications or blood pressure medicines or diabetes medicines are so harmful, and they're never going to take it, and they want to get an opinion from us. And if you look at some of the TV commercials for things such as empagliflozin, they talk about some nasty side effects there. So I can see why some patients don't want to take that medication. They don't put that in perspective that it's extremely rare. But many times what Dr. Sperling and I try to do with patients is gain their trust, and it may be that we cite some of the work that an article that Emory had published many years ago that even taking a statin like rosuvastatin twice a week can lead to about a 35% reduction in LDL. And I often do that. I cite that one of those studies from Emory, and then if people can understand a little bit better that they can tolerate the medicine, they don't have any side effects, and they you can tell them that we have this data that if you can get your numbers much lower, we have a much better chance of stabilizing the plaque buildup that you have and maybe getting some modest reversal. Then they're more likely to continue and go on medicine. But I think gaining the trust is so important, whether you're a primary care physician, internal medicine, but especially, a cardiologist. And many people think that supplements are the answer, and all prescription medicines are flawed or potentially harmful. And trying to put things in perspective and using a little bit of psychology and motivational interviewing can go a long way in preventive cardiology.
Yeah, absolutely. And I think, from a personal perspective, I think the whole reason I went into medicine and wanted to do cardiology is the fact that it's such a gift for patients to put their lives into our hands and they trust us to help guide them. And I think I love that we're talking about the core of prevention is trust, because without that, building that strong relationship, you can't really move forward. And I absolutely know what you're talking about when you mention people taking statins twice a week, because that's what my mom does for now. um, but I think when I talk to patients about it and I tell them I'm a little bit more understanding because I have talked to my mom about this, I think it just creates this connection where they're like, oh, okay, so she's actually talking about this with her family members, and she's actually, this is something that she talks about on a regular basis. And I think it really allows them to feel listened to instead of just kind of shutting it down completely.
It's people also come to see us from different backgrounds, educational backgrounds, and I think trying to figure out on what level to base our conversations. And we also, some of the societies like the National Lipid Association and ASPC, have very good patient centered handouts for various educational levels. The AHA has, and the CardioSmart from ACC also has some very good handouts that may take into account some person's different backgrounds, ethnicities, et cetera, and what some of their dietary habits might be and how to modify those too.
Yeah, absolutely. Absolutely. Well, I kind of want to wrap it up with the last question, just since we've talked a lot about what we did before, how we got to where we are. But I'd love to know, from your perspective, where is the future of preventive cardiology heading? And how do you think that programs, you've talked about it's a constant evolution, you're changing things and adapting and adding things every day to your programs. How should programs really evolve to meet those changes that are coming to the field?
Yeah, really important. There's never been a more exciting time to be a preventive cardiologist. As I think back over the last decades that I've been involved with, but many of us have been involved within those building blocks that you talked about for our fellows or our young faculty. Think ahead and say, boy, where are we today? It's very exciting. I mean, we have incredible pharmacotherapies that are literally game changers, and likely that will continue to happen. Very uniquely and specifically designed to continue to reduce the likelihood of cardiovascular disease and cardiovascular disease events. We have better and better ways of prevention, early detection. We now can image looking at plaque and flow and plaque composition. So the question of, regression versus pregression. I mean, we'll be able to do that in clinical care, not just in research. The scientific knowledge is exploding, but we must continue to anchor this in implementation science and public health. Because although we've learned a lot over the past 3 decades, there continue to be major gaps in care. And those gaps are in those ABCs that Dr. Blumenthal talked about. And boy, you think we'd learn how to spell after so many years of doing this, but we haven't quite gotten there. And so we need to invest in implementation of what we have and what we will have in the future. If we can do that, and if we can invest in public health, and as a part of what we do in clinical medicine and anchoring that in the community, the future is bright.
That's well stated, Dr. Sperling. I think, listening to you speak, reminded of the fact that you and I have always said that the cornerstone of prevention is optimizing lifestyle habits, and we can, some people we've said people will say, well, I won't take a medicine until you can show me I have end organ damage, meaning plaque in the heart arteries or the neck arteries, but I think, the first statin came on the market in 1987, Keerthana. So we have a pretty good track record that lipid lowering is pretty safe and effective. And I think we're moving more and more to the idea of trying to prevent the development of calcified um, plaque and elsewhere in the body. And just to sort of close up, Dr. Brunwald and Dr. Rob Califf many years ago had said, from a primary prevention perspective, they looked at the data and said they wanted their LDLs to be, essentially 55 or less, 50 or less, and uh, they hadn't had any cardiac events, but said they went on statin and ezetimibe early on, and I think many more of us think about that and say, we should be starting these medicines sooner if you have any family history or if you have another risk factor and you can't optimize things through lifestyle. We got to keep the idea about cost effectiveness in play, but just as Dr. Sperling said, we have some great, exciting technologies that are there. We just can't use them all for everybody, but I think more and more people will be thinking about prevention moving forward. And if we can keep people motivated to think about each and every day, what can they do to add on some better lifestyle habits, that'll be a big success.
Yeah, what an incredible conversation. We covered so many topics, and starting from your own personal journeys, thank you for sharing those, to talking about how we build a team, focusing on our team members and really that champion who's going to be part of it, the vision, reminding ourselves to have grace that these things don't happen overnight, and really finding what you want to focus on to grow your program. My favorite part, the ABCs, of course, and talking about really, I loved that we talked about not so much about myth busting, but focusing on truth and presenting evidence with which we're able to further educate our patients. And also talking about where prevention's headed and the cornerstone of prevention and optimizing lifestyle changes. I know I am leaving this feeling incredibly inspired and excited. And I'm so grateful that you both took the time to chat with me. And I'm very excited to meet you all in person, not via video, at the ASPC conference as well.
Well, we look forward to seeing you in Boston, Keerthana. It'll be a lot of fun.
Yeah, and thanks to ASPC for inviting myself and Dr. Blumenthal for this podcast. Really, really special to me to join him and to join you, Keerthana, for many to listen about how they can build their own preventive cardiology programs, because we need more of these in our country and globally.
Yeah, thank you guys so much.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.